Today, I want to talk about something we all encounter in practice, but probably don't think too deeply about: chewing gum. Specifically, I'm going to walk you through the evidence behind xylitol gum for caries prevention, address some cardiovascular concerns that made headlines, and along the way, we'll cover an oral pathology pitfall that's worth knowing. Let's start with a case that brings this all together. Here's a 42-year-old female presenting with a chief complaint of generalized burning sensation on the left side of her mouth. Take a look at these images. On the clinical photo, you can see white, non-detachable plaques on an erythematous background involving the buccal mucosa. The histiopath shows a band-like lymphocytic infiltrate located directly under the epithelium and attached to the basal cell layer. At higher magnification, you'd see eosinophils and plasmacytes. There's also a perivascular lymphocytic infiltrate deeper in the connective tissue. So what's your differential? Lichen planus, lichenoid mucositis, maybe lupus? All reasonable considerations, but there's a key piece of history we're missing. The diagnosis is cinnamon contact stomatitis. This patient chewed big red gum daily, and the culprit is cinnamaldehyde, the flavoring agent in cinnamon products. Here's the clinical pearl. She stopped the gum, and within 1 week, complete resolution. You can see in the follow-up photo, the buccal mucosa looks essentially normal, with just a couple of petechiae remaining. This is a classic presentation. Notice the location, white and red lesions right at the occlusal plane level. That's exactly where the gum contacts the tissue during chewing. 100% of cinnamon contact stomatitis cases resolve within 1 week of stopping the offending product. Remember that. We'll come back to it. So this raises an important question for us as clinicians. As dental professionals, what can we recommend to our patients that can prevent caries and avoid this contact stomatitis issue? The answer is actually quite simple. Xylitol mint flavored gum. But why xylitol specifically? Let me show you the science behind this recommendation. So what exactly is xylitol? Xylitol is a 5-carbon sugar alcohol. It's naturally found in small amounts in fruits and vegetables, and it's also derived from birch trees. It tastes like sucrose, same sweetness level, but it has 40% fewer calories. And look at that glycemic index. Xylitol is 11 compared to sucrose at 64 and glucose at 100. So it's also a good option for diabetic patients. It's FDA approved and classified as safe for human consumption. But here's the key difference that makes xylitol special for oral health. It is non-fermentable by oral bacteria. Unlike sucrose, unlike sorbitol, unlike maltitol, bacteria cannot convert xylitol into acid. But it actually goes even further than that. Xylitol doesn't just avoid causing harm, it actively fights back against cariogenic bacteria. Let me show you how. I like to call this the Trojan horse effect. Here's what happens at the molecular level. Step 1. Streptococcus mutans takes up xylitol through its fructose transport system. The bacteria thinks it's getting sugar. It can't tell the difference. Step 2. The bacteria phosphorylates xylitol to xylitol 5-phosphate, or X5P. Step 3. Here's the problem. X5P cannot be metabolized any further. It's a dead end, so it accumulates inside the bacterial cell. Step 4. This accumulation depletes ATP. The bacteria essentially starves. Growth stops. Step 5. And critically, no acidic byproducts are released, so the pH of the mouth stays neutral or even increases. This is why xylitol is specific. It's not just non-cariogenic like other sugar alcohols. It's actually anti-cariogenic. It actively harms the bacteria that causes cavities. Now you might be wondering, what about other sugar-free gums? What about sorbitol or maltitol? Do they work just as well? Great question. Let's look at the best evidence we have comparing xylitol directly to other polyol sweeteners. This study from 2017, published in Clinical Oral Investigations, is important because it's the highest quality randomized controlled trial we have, comparing xylitol gum directly to sorbitol gum. Let me walk you through the study design. This was a randomized controlled double-blind trial, the gold standard. They enrolled 130 adults between ages 30 and 45, and these were high-risk patients. Everyone had salivary mutant streptococci counts greater than 10 to the fifth. The intervention period was 1 year of gum chewing, with 2 years of total follow-up. The primary outcome was change in total caries experience, measured by the DMFT index. That stands for decayed, missing, and filled teeth. Now here's what's interesting about the intervention. The xylitol group only received 2.5 grams of xylitol per day. That's actually lower than the typically recommended 5 to 10 grams, and they chewed just 3 times daily. The control group received sorbitol gum at the same dose and frequency. So what were the results? The xylitol group had a significantly lower caries increment compared to the sorbitol group, at a p-value of 0.01. The prevented fraction was 31%. That means xylitol gum prevented approximately 1 in 3 new carious lesions compared to sorbitol gum. They also found that salivary mutant streptococci decreased significantly in the xylitol group at 12 months, while there was no change in the sorbitol group. The clinical implication here is important. Even at doses lower than we typically recommend, xylitol gum provides significant caries protection in high-risk adults. This supports its use as an adjunct to standard oral hygiene. Now, I know what some of you might be thinking. What about those cardiovascular headlines from 2024? You may have seen the European Heart Journal that linked high circulating xylitol levels to increased cardiovascular events. This made headlines and concerned a lot of patients, and probably some of you as well. But here's the critical context. Dose matters. The mechanistic studies that showed platelet activation and enhanced thrombosis used 25 to 50 gram boluses all at once. That's like eating an entire pint of xylitol-sweetened ice cream in one sitting. Gum consumption, by contrast, delivers 5 to 10 grams per day, spread out over multiple chewing sessions, with slow absorption through the oral mucosa. The pharmacokinetics are completely different, and importantly, Mendelian randomization studies do not support a causal link at dietary doses. The elevated plasma xylitol levels observed in those observational cohorts likely reflected underlying metabolic disease, things like diabetes and obesity, not dietary xylitol intake. But here's where it gets really interesting. There's actually a paradox here. We have a double-edged sword situation. On one hand, we have theoretical xylitol cardiovascular risk at high doses, which remains unproven at typical gum doses. On the other hand, we have proven cardiovascular risk from dental caries. The ARIC study, that's the Atherosclerosis Risk and Community Study, followed over 6,000 participants for 21 years. They found that dental caries increases stroke risk by 40%. So here's the bottom line. The cardiovascular benefits of preventing dental disease likely outweigh any theoretical risks from moderate xylitol gum use. We're not choosing between risk and no risk. We're choosing between a theoretical risk and a proven risk, and the math favors xylitol. We've talked about caries prevention and cardiovascular considerations, but there's another patient population that particularly benefits from xylitol gum, and that's patients with xerostomia. Dry mouth is incredibly common. It affects 20 to 30% of adults, and that number is much higher in elderly patients and those on multiple medications. Anticholinergics, antidepressants, antihypertensives, the list goes on. Here's why xerostomia matters for everything we've discussed today. When salivary flow decreases, you lose buffering capacity. The oral pH drops, caries risk increases. Some studies show up to 3 times higher caries rates in xerostomic patients. But it's not just caries. Dry mouth worsens oral mucosal lesions. Candidiasis thrives. Burning mouth symptoms intensify. Traumatic ulcers heal more slowly. The tissue integrity is compromised. So how does xylitol gum help? First, the mechanical act of chewing stimulates salivary flow. That's true of any gum, but xylitol gum has an advantage. You get the salivary stimulation without the sugar-induced acid production. The Hashiba study from 2015 actually measured this. During field training conditions where participants couldn't maintain normal oral hygiene, the control group had significant increases in subjective oral dryness, with a p-value of less than 0.001. But the xylitol gum group, no significant increase. Their dryness scores stayed stable. The gum prevented the dryness from developing. So for your Sjogren's patients, your patients on xerogenic medications, your post-radiation patients, your elderly patients, xylitol gum is doing double duty. It's preventing caries and maintaining oral moisture. This makes it an ideal recommendation for some of our most vulnerable patient populations. Now let's circle back to where we started, that case of contact stomatitis, and talk about flavoring reactions. If we're recommending gum to patients, we need to think about flavoring. Let's compare cinnamon and mint. Cinnamon contact stomatitis is well documented in the literature. The largest study from 2025 reported 74 cases. There are over 40 additional well-documented cases in the literature. The causative agent is cinnamaldehyde. The most common sites are buccal mucosa at 91% and lateral tongue at 68%. The presentation is typically white and red lesions at the occlusal plane. And here's the key point. 100% of cases resolve within 1 week of stopping cinnamon products. Now let's look at mint. Mint and menthol reactions are rare and less well defined. The largest study from 1995 found only 12 cases over 4 years. The causative agents include menthol, peppermint oil, and carvone. Presentations include burning mouth and oral lichenoid lesions. But here's an important detail. 9 of those 12 patients had other positive allergens on patch testing. This suggests mint sensitivity is often part of a broader allergic profile, not an isolated reaction to mint. The comparison is stark. We have over 100 documented cinnamon cases in the literature, versus only about 12 to 15 mint cases total. This brings us to a clinical pearl you can use tomorrow. Here's a simple diagnostic algorithm for suspected contact stomatitis. If the lesions resolve within 1 week of stopping the suspected product, diagnosis confirmed, contact stomatitis, no biopsy needed. If the lesions persist beyond 1 week, that's your red flag. Biopsy is indicated. You need to consider other diagnoses like true lichen planus, lichenoid drug reactions, or something else entirely. 100% of cinnamon contact stomatitis cases resolve within 1 week. This is a reliable diagnostic criterion. So let's put this all together. What should we actually recommend to our patients? First, let me be absolutely clear. Xylitol gum is an adjunct, not a replacement. The foundation of caries prevention is still brushing twice daily with fluoride toothpaste and flossing daily. Nothing replaces mechanical plaque removal. Xylitol gum is what you add on top of that, especially after meals when brushing isn't practical. With that foundation in place, here's the xylitol prescription. Recommend xylitol gum after meals 3 to 5 times daily. This is when it's most beneficial, right after eating, when the oral environment is most acidic. Tell patients to look for xylitol as the first ingredient on the label. Many gums list sorbitol first with just a small amount of xylitol. That's not what we want. The target dose is 5 to 10 grams per day. Most xylitol gums contain about 1 gram per piece. So that's 5 to 10 pieces spread throughout the day. For patients with a history of oral sensitivity or allergic reactions, consider recommending fruit-flavored options. This avoids both cinnamon and mint. Counsel patients to report any new burning sensations or oral lesions. We want to catch any reactions early. Mention the GI side effects. Xylitol can cause bloating, flatulence, and diarrhea at high doses. This is rare at typical gum doses. And finally, and this is important, xylitol is toxic to dogs. It causes severe hypoglycemia and liver failure in dogs. Always warn pet owners to keep xylitol products away from their pets. And here we have DJ on the right, standing behind our favorite xylitol flavored product, Zelly's Peppermint Gum. Thank you for listening.